medical education and continuing pharmacy education programs. Rebecca, if you want to go to the opening slide for us. So this particular event is called Improving Patient Care Access Through Electronic Referrals and Consults. And we're going to take some lessons from the West Coast, the East Coast, and we're going to share them with our audience with the hope in mind that we will be able to expand and enhance what we do going forward in Connecticut. So let me go ahead and go to the next slide. This is a webinar that's funded through grants from the Office of Health Strategy and from our Health Information and Exchange in Connecticut called CONI. Neither of these has any influence on the content of this program. The next slide, basically, we are doing continuing education and continuing pharmacy education series, and it's called Health Information Technology for Clinicians, How to Achieve Optimal Outcomes. I'm Tom Agresta. I'm your activity director and moderator for this series, and I'm from the Department of Family Medicine and Center for Quantitative Medicine at UConn Health. Next slide, please. The other topics that we have considered and will continue to consider in this series relate to medication safety and reconciliation. We've had some series on telehealth and health information exchange, and also some information on patient-generated healthcare data and remote patient monitoring. We will continue to seek ideas from our audience about additional topics they'd like to have covered. Next slide, please. Our learning objectives for today are we're going to be able to describe the difference between standard referrals and electronic consults, or an eConsult and an eReferral, and discuss the additional value an eReferral can provide and the benefits of an eConsult and eReferral for patients and providers. And we're going to talk about both clinical referrals as well as referrals made on social determinants of healthcare needs. We'll identify challenges and best practices to applying these in practice, and we'll describe a little bit about how a health information exchange could facilitate eReferrals and eConsults in Connecticut, and some information about a recent survey we had done that some of you may have participated in. Next slide, please. A little bit of housekeeping. Your attendees' lines are muted. The panelists will address questions at the end. There is a question and answer feature in WebEx, and we would ask that you put your questions into there or into the chat, and we will listen to those questions and address them at the end. This session is being recorded and will be available afterwards by video on a URL, which we will share with you all. And if you are seeking continuing medical or pharmacy education credits, instructions about how to do that will be provided at the end. Next slide, please. Now I'd like to introduce our presenters. Our first presenter is Dr. Paul Gibney. He is a general internist and actually he's a family physician. Sorry about that, Paul. He's a family physician and associate chief medical officer at the LA County Department of Health Services, and he has been working in the eReferral, eConsult space for a number of years. Our next panelist is Darren Anderson, who is a general internist in Connecticut, and he's currently the vice president or president of ConfirmMed and vice president and chief quality officer for the Community Health Center Inc. and CHC Inc. and has helped set up a eConsult network in Connecticut. And our last presenter is Mark Rabner, who is a pediatrician and director of clinical applications for CRISP. CRISP is the technology vendor for our health information exchange in Connecticut. And there is a disclosure. Dr. Anderson does have a financial interest in ConfirmMed, but we are not going to be discussing specifics of that company during this presentation. Next slide, please. Let us do a little bit of ground setting about the difference between an eConsult and an eReferral. And E means that the information is traveling electronically between clinicians. And eReferral it would be akin to having the information about a referral where we expect the patient to be seen by the specialist, for example, if they're being sent from a primary care clinician to a specialist, but the information would all travel electronically, but the expectation is the patient would first meet the specialist in person. An eConsult is a tool that is designed for an asynchronous bidirectional communication between the, say, for example, the primary care clinician and the specialist without the need to actually have the patient be seen in person. And there's some pros and cons to how each of these things work, and our panelists will get into much greater detail about it and also discuss how the data is transferred in these settings. So I'm going to go ahead now to the next slide and pass it along to Dr. Paul Gibney.
Thanks, Tom. It's great to be with everybody today. It's morning for me, but it's starting the afternoon for all of you. Speaking to you from Los Angeles, and where I am, as Tom said, Associate CMO for LA Department of Health Services, which is the second largest public health system in the United States. We can go to the next slide. Thanks, Rebecca. So back in 2011, when I joined our department, we were in a pretty rough spot. We had a very large, fragmented, siloed system. We have 4 hospitals, over 20 clinics, a large network of community partners, clinics that we serve, federally qualified health centers. And back then, we just had really long wait times for specialty services. You can see the slide there. 6 to 12 month wait times, oftentimes. Surgeries, elective surgeries were more than 18 months. And the impression from the users of our system were that when they sent us a specialty request, it just kind of fell into a black hole. And we weren't doing a very good job of coordinating among our facilities or with the FQHCs in our community, of which there are over 200 FQHC sites or locations in Los Angeles County. And that kind of resulted in this very discoordinated system, and there was a lot of variability. So we came up with eConsult. Rebecca, you can go to the next slide. So when we thought about eConsult, as Tom said, it's a discussion. We consider it almost a pre-referral conversation. Basically, a primary care doctor who has a specialty need will send a message through a web platform to the specialist. And we require our specialists to reply within 4 calendar days. That includes holidays, weekends, etc. And dialogue ensues. And together, the primary care doctor and the specialist determine what are the best next steps for the patient. And the possible outcomes of this is sometimes it does, more frequently than not, ultimately result in an in-person video or phone visit with the specialist. But it can also result in the specialist taking a look at a picture, taking a look at the records, hearing the history or the clinical presentation of the patient, providing some advice to the PCP, who then continues to care for the patient in the medical home. And then sometimes the specialist will say, wow, this is a really interesting case. I'm probably going to need to see them, but why don't you get a treadmill first, or an echo, or a CT scan, or an MRI, and then we'll discuss the results of that before we make decisions as to the next step. We can go to the next slide. And so what we feel like is the second an eConsult begins, access to specialty care has already begun. Because the PCP is getting rapid access to specialty expertise. They're actually getting the input of the specialist on the patient before the patient actually might go and see the specialist in person if that's indicated. And what we found is there's a number of big advantages to this. The specialist is able to take a look at the case very early, decide if they need to expedite the care, or if they want to designate the care, but at a particular timeliness. For example, a dermatologist might get a case, look at the rash, or look at the photo, and say, yeah, I'm probably going to need to see that patient in clinic, but go ahead and get this cream started. And then instead of seeing them in 2 weeks, I actually want to see them in 6 to 7 weeks, because I want to see what the efficacy of that cream was. and then make clinical decision making from there. It also allows the PCP to deliver some level of specialty care in the medical home where they may speak the language of the patient better, or maybe better parking or closer to the patient's home. And what we found is that when the patient does need a face-to-face visit or an in-person visit, or a phone visit or a virtual visit with the specialist, oftentimes those times are faster and reduced because we removed the low-value specialty care visits from the system. We can go to the next slide. Our network is very large. We have over 5,000 providers that have submitted electronic consultations. And you can see there that we have medical centers, we have health centers, we have FQHCs, we have our public health clinics, we have our juvenile courts clinics, we have the jails submitting eConsults to us. We have our Department of Mental Health clinics. And all in all, we've got pretty much every specialty you could want on eConsult. Over 600 specialists are reviewing those eConsults. And we also have made community resources available to us, help with social determinants of health and other things like smoking cessation, food insecurity, nutrition, diabetes, exercise programs in the community. We have one of the local YMCAs on our network, and it's really a broad and robust network. We can go to the next slide. So we're currently responding to almost 20,000 eConsult requests each and every month in our Department of Health Services, and we've actually done 1.5 million of these since we launched the program in 2012. Even over all that time, our median response time to an eConsult request is still around 24 hours. Oftentimes, if we have really star specialists responding to these, we will get responses within minutes. And we've done some publications on this, and we demonstrated that our program was able to decrease wait times to see specialists. And also, like I said, it allows us to triage and decide what kind of modality is best, especially during COVID. It was very powerful for our specialists to be able to say, okay, for those patients that I want to have a personal conversation with, can I do that assessment by phone or by video, or do they need to come into the hospital in person? And so during COVID, this was an incredibly powerful tool for us. We can go to the next slide. What we found is over all of these specialties on eConsult, which is all of them, about 25% of them are resolved without ever needing a specialty visit. And I think one thing that's really important to understand about our system is we require all of our PCPs for non-urgent, non-emergent specialty requests to start with an eConsult. So this is not optional. This is the way to initiate a request for non-urgent specialty care in our system. And so many descriptions of eConsult programs you'll see will have a much lower rate of conversion to a specialty visit, but those are usually programs where the PCP has the option to use a traditional method or eConsult, and ours, it's everybody. And so depending on the specialty, that percentage changes. So for specialties where there's a lot of cognitive activity, where you can learn a lot from laboratory results, like hematology or endocrinology, we only have about a 50% conversion to a in-person or a telemedicine specialty visit. For specialties that require an extensive exam by the specialist, for example, ophthalmology, our conversion to a face-to-face visit is 90%. But even in that case, the specialist knows why they're there. They've often asked the PCP to make sure that the clinical information or any diagnostic information is complete before the face-to-face visit. So even that, in that case, it leads to a higher value first visit with the specialist. And what we found in our analysis is that the more back and forth pieces of dialogue the specialist and the PCP conduct, the more likely it is to result in care delivered without a face-to-face specialty visit. We can go to the next slide. So I wanted to take the next couple slides and kind of share you what it looks like from the different participants in this interaction. And, you know, obviously we start with the patient. We believe this is incredibly patient-centric because what it does is it avoids low-value specialty visits. And in many current systems, the patient is the one who is inconvenienced. Oftentimes the PCP will say, well, I think you need to go see the cardiologist. And so they write to the cardiologist, please eval and treat. So the patient takes a day off of work, maybe arranges childcare for their kids, take 2 buses across town, go sit in front of the cardiologist, and the cardiologist says, well, why are you here? And they describe their problem. The cardiologist says, oh, well, we need to get an echocardiogram or a treadmill, and then we'll see you back for a more definitive second visit. And what eConsult has done is it has removed that, because in eConsult, the cardiologist will say, well, I probably want to see the patient, but to the PCP, can you get an echo, get a treadmill, and then get back to me with those results, and then we'll decide if the patient needs to come and see us in the cardiology clinic. And so what it does is it really improves the patient's experience because they're not wasting time to attend low-value specialty visits. So it's less travel, fewer days off of work. You can see the slide. The PCP is more informed. They're actually dialoguing with the specialist, which is really powerful for the patient because that means both parties are coordinating care. And then the timeliness recommendations are really key because then the patient is arriving to the specialist in the right location with a specialist who knows that they have the capacity to deliver all the care that patient needs, because we have multiple locations in our system, and some locations have different capabilities than other locations with regards to specialty care, and so we're able to direct the patient to the right specialty location. We can go to the next slide, Rebecca. For the primary care doctor, it's really great because within 24 hours, they're getting specialty input on the care of their patient, which looks a whole lot better than 6 to 12 months like we had before eConsult. For our PCPs out in the community, it reduces their sense of isolation. They're able to learn a lot from those interactions. It is reducing wait times for our patients, the things more coordinated. But the PCPs do experience some challenges. We did some inquiries, and the PCPs sometimes felt like they're now managing some things that maybe they didn't used to manage. Maybe they used to just be able to offload them to the specialist and not think about them anymore. And now the specialist is asking them to start that cream or manage that hypothyroidism a little bit more. And so there is a sense from our PCPs that sometimes they have more balls in their court. But what I've continually stressed to our primary care doctors is that you have more balls in your court, perhaps, but as long as you are getting the support you need to do it, it's better for the patient. Because when we can deliver care in the patient's medical home, it truly is more patient-centric. We can go to the next slide. For the specialist, it really helps because they are able to extend their impact over a very large population of care, not just those patients that happen to navigate through the system, make it through all the different hurdles and barriers in a big bureaucratic county system, and finally get to see the specialist in person. The specialist is now able to leverage their expertise over a very large population. They can triage like we talked about. They can bring some patients to see them very quickly. They can ask other patients to come at a later time frame because they want to see the impact of an intervention. It really reduces no-shows because they're able to coordinate more effectively. And then the face-to-face visit is much more impactful. We're much more likely to get a definitive first visit with the specialist instead of waiting for a definitive second visit. And in a system that is highly impacted, that makes a big difference. And then, like I said, during COVID, it really enabled the specialist to care for a greater percentage of their patients remotely or designate them for a phone or a video visit. So anyway, I'm going to wrap it up at that point and hand it off back to Tom. But always more than happy to field questions either by email or during the remainder of this session.
Excellent. So thank you, Paul, for that. A quick question, it did come in that maybe you can answer while I'm sharing the poll. it related to whether eReferrals also included referrals to like physical therapy and labs and radiology.
Yeah, so our eConsult dialogue platform is mostly for a typical specialty request, but we do put for our community partners radiology on the platform. We put physical therapy, occupational therapy, speech therapy, nutrition, audiology, a lot of other ancillary services on the platform. Some of those are more in the form of an eReferral, which is more of a one-way request without an expectation of dialogue. But what we have done with a couple of the more advanced radiology studies, like a PET scan or an MR angiogram, we actually do have the requesting provider dialogue back and forth with the radiologist to make sure that that is actually the best call for them.
Okay, excellent. Folks should be seeing the poll at this point. If for some reason you're not, let somebody know in the chat box. But the question is, are you able? What do you think is the most significant difference between a standard referral and electronic consult and referrals? So go ahead and take a little bit of time to answer that. I'm going to I'm going to have them move on now and actually introduce Darren Anderson and have him start his work, and you guys can continue to answer that while we move on and have Darren present, and then I will share the results of that poll after Darren finishes. So go on to the next one for us.
Great, thank you, Tom. And it's really an honor to present immediately after Paul Gibney, who in my mind is and experience is a rock star, and actually is one of the people that we turned to back in 2010 or 11 when we were looking to set up an eConsult process here in Connecticut, and learned a lot from him and from the LA County team, as well as another group of people in San Francisco that were experimenting with, at the time, what was this new concept of eConsults. And so the first thing that I want to say is ditto. Everything that Paul laid out are things that I normally would lay out in an eConsult discussion, but I'm not today. Paul's made a really strong case, first of all, for what eConsults are, why they're beneficial, and sort of how the system works. So what I'd like to do is to talk about how we took many of the ideas and concepts about eConsults that we learned from Paul and others and applied them to a very different setting, Connecticut, not just Connecticut versus California, but a different healthcare delivery setting, and how we tackled and overcame some of the unique challenges that our setting presented. And I also want to talk a little bit about some of the evidence that we were able to accrue. We knew at the outset that one of our challenges was going to be convincing people to pay for eConsults, finding a sustainable economic model for that. And so we actually started through the Weitzman Institute a series of studies designed to look at the safety and impact of eConsults as well as the economic consequences. And I'm going to go through those findings very briefly. I presented on them before, but you can go on to the next slide, Rebecca, and I'll touch on that. So the challenge, so Community Health Center, Inc., the organization for which I'm the Chief Quality Officer, and at the time was a medical provider, primary care provider, general internist, and medical director. We faced a unique challenge. Although there's fewer people in Connecticut than in LA County, I suspect we did not have the luxury of a single entity where we were making referrals to, unlike the county system in LA. Our primary care providers practicing across the state in over 200 locations are admitting to Bristol Hospital, Waterbury Hospital, St. Francis Hospital, UConn Hospital, Hartford Hospital, L&M, Norwalk, Stanford, and I could go on, and working with specialists from all of those different locations. And whereas the challenge of bringing on board one group of specialists from one hospital is a big one, engaging all of the specialists across the state to do something like this was a hurdle that we simply couldn't overcome, certainly not back in 2011 when this idea was still new. So we had to design a system that would be sort of almost agnostic to where the specialist was located and would provide a primary care provider wherever they were in the state with quick feedback, just as Paul laid out, from a specialist to help them exactly as has been described, decide how to manage the case, what to do while you're waiting for a visit, and ultimately whether the visit needed a face-to-face encounter or not. And we had 9 to 12-month waits to get patients in to be seen, similar to what Paul described. So we spent a fair amount of time in the design phase, but in 2015 implemented a statewide eConsult program with what I like to call a centralized cloud-based specialist process. We recruited specialists, early adopters, and people that were excited and interested in this idea. Some were from UConn, some were from Starling Physicians, some were from Community Medical Group, and others came from different practices across the state. And they signed up to work with us. We reimbursed them for their eConsults, and we gave them access to a web-based portal where they could log on and view the information that we presented to them and respond back to the primary care provider. And since that time, we've done 15,000 eConsults. I'm embarrassed to put that number up after having heard 1.5 million in LA, but nonetheless, we're proud of it. And also, as Paul outlined, 81% of those consults have avoided an unnecessary face-to-face visit, and that is for about 38 adult and pediatric specialties and subspecialties. So I can have the next slide, Rebecca. I want to go through the data that we collected. So we've actually published 7 different papers on various aspects of the way this process worked. I'm going to highlight 3 of them very briefly. The first one was a randomized controlled trial with an intention to treat analysis where we randomized all of our CHC clinicians. Half of them got to use eConsults, half of them didn't. And we studied the outcomes of their patients, those that got access and those that didn't, to determine a variety of things about how this eConsult process worked. It was a 1-year intervention. The details I'm happy to share at the references there on the bottom. But what we found, we did this for cardiology, and we used UConn cardiologists, and we found that 69% of all the consults that were sent in for cardiology addressed the question without the need for a face-to-face. It reduced our wait times across the whole system. And interestingly, and this gave us a little glimmer of what we might see in future work, we saw that the providers and patients who were using eConsults had lower ER utilization than their identical panels and providers who didn't have eConsults. And that gave us a hint that there was something going on here that might have impact more broadly across the health system. Next slide. So we followed up that same study using the same patients with a cluster randomized trial where we pulled out the Medicaid patients specifically in that study, equated to about 360 patients. And we also, again, collaborated with UConn Health and with Department of Social Services with a full, who provided us with access to claims data for all the patients in the study. And with that, we were able to show that not only were we reducing wait times and reducing unnecessary face-to-face visits, but that equated to about $466 per patient in savings for Medicaid. If I could have the next slide, we expanded that analysis in a non-randomized trial and added on 4 additional specialties: endocrine, orthopedics, GI, and derm. And again, using claims data from DSS, we're able to show that as we expanded, Medicaid over a 6-month period was saving approximately $82 per member per month, which equated to about $500,000 in savings for just those 4 specialties over a 1-year period. This evidence, we felt, published in Health Affairs, was conclusive enough to convince DSS that this was a benefit worth covering. And Connecticut became the first state in the country, first Medicaid program in the country to authorize reimbursement for eConsults based on this result. And about a year later, CMS added eConsult codes to their list of telehealth codes, which were eligible for reimbursement. If I could have the next slide. So, and then finally, Milbank Memorial Fund published a white paper in May of 2020, which summarized our results were highlighted in this, along with Paul's and many others, to really release what I think is a great review article describing eConsults and, as it says, a triple win for patients, clinicians, and payers. Basically, I think confirming and expanding upon what we had reported, that it improves access, it's more efficient, patients and clinicians generally like it, and it lowers the total cost of care. Really a win-win-win for everybody. Next slide. So on the wings of all of these findings, and you can go on to the next slide, we decided to really take this concept and expand it. we added multiple specialties from the 4 that I shared up to the 38 that I mentioned. And some additional practices in the state of Connecticut expressed interest and over the ensuing years joined. Griffin Hospital has been one of the earliest systems to work with us and use our eConsult service. AmeriCare's free clinic in Stamford, ProHealth Physicians recently has joined on to use eConsults with our system as well. And we've slowly been chipping away at the list of payers that are reimbursing for eConsults. Sadly, Medicaid suspended reimbursement at the end of 2019 in their wisdom and through the feedback from CMS, concluded that Medicaid programs were not authorized to get reimbursement for eConsults the way this had been set up. Other states have seen differently and have authorized them, but for better or for worse, they no longer are covered. But Anthem has, Connecticut has. We have a pilot eConsult program with Cigna, and several other payers are looking at this as well, which gives us an opportunity to make this available to a broader population of patients with a sustainable reimbursement outside of grants. I didn't mention, but the work that I shared was funded by grants, first from the Connecticut Health Foundation and then from several other private foundations that have helped us with this work to really get it stood up and launched. Next slide. So as I mentioned, we really sought to expand this and make this something that would live beyond grants and provide services and support in the same way that Paul and the LA County program have outlined, but in the context of Connecticut across the state. And we developed a process to recruit. We've now brought on over 225 specialists. They're board certified. We credential them ourselves. And these are the specialties that we're now providing, from adult and pediatric specialties and subspecialties, as you can see. Next slide. So here's where I think this today's webinar brought to us by with the overarching umbrella of the topic of the HIE. Here's where we really have gotten creative. We don't have an HIE, although we're excited about the prospect of having one. And we're working with now health systems and clinics and practices with different EHRs and different systems. We had to get really flexible with how we got the information out of the EHR and into our portal. Our specialists are all working off of an online portal that we own and that we provide to them. But the information is coming from people on ECW, people on Cerner, people on Epic. And so we've created a very flexible system that basically is, we'll work with you where you are. I have practices now working with us that are on fax, that fax us paper. We have others where we're using Epic and Epicare Link to connect, but we've used, you can see, a variety of technologies to make sure that from the primary care practices perspective, they can communicate the information to us using a HIPAA secure process, and we can get it into our portal. And I have a team of referral coordinators whose job it is to basically convert the format that is coming in through into and add it onto our online portal and route it to the appropriate specialist. Next slide. And I will say this is a place where the presence of an HIE would make the work that we do enormously, much easier. We have taken this concept and expanded it across the country, and we're now providing those self-same consults in almost 20 states now, and we've done 60,000. Next slide. So let's talk about Connecticut and why, although, as I mentioned, we started in Connecticut, we've expanded to other states. We have faced a lot of challenges to wider adoption in this state. Although we've introduced this in a variety of different settings, in different hospital and primary care clinics, we have not seen outside of CHC-wide adoption. And there's a variety of reasons for that, and I think Paul touched on them. And one of them, I'm just going to be blunt, I'm speaking as a primary care provider, but PCP resistance. Many primary care providers are comfortable with sending people to the specialist in their region or in their neighborhood who they have a relationship with, and they like the ability to offload that workup and evaluation to somebody else. We are still largely in a fee-for-service environment where some people describe it the hamster wheel, where you're cranking through patients as quick as you can. eConsults, some feel, add more work, where now they have to do workups themselves rather than send them out. This really requires leadership commitment to implement a change like this, and change management presents challenges. Just by human nature, not everybody is open and up for things that are different than the way they used to be. And we have a lot of misaligned incentives in our health system in Connecticut as well. If everybody was aligned around shared savings and shared risk, and we were all benefited by providing efficient care in the least expensive way possible, we would have less difficulty than adding more work on the back of a primary care provider who is getting fee for service and essentially being reimbursed based on the number of visits they see in a typical day. And so that's made Connecticut a more challenging environment to implement eConsults. Also, to speak bluntly, which as those of you who know me, I always do, specialty groups and hospital systems aren't always on board with the idea of reducing the flow of patients into their system for the reasons that you all can imagine. That's not, in our current environment anyway, always a positive thing, depending on your perspective. And limited payer participation, although as I mentioned, that is rapidly improving, has limited the patient panels for whom eConsults are available today. All of these things are changing. We are very busy working in other states where shared risk and shared savings arrangements are more common, and those things are coming here as well. And so we are very much expecting to see more uptake of this type of a program as the incentives align. Next slide. So, and I'm sorry, I'm on the last slide, opportunities. And so I think as advanced primary care, the concept of really empowering a primary care practice to manage as much as it can for the patients that it serves, eConsults are very much aligned with that idea of having in your back pocket a digital connection with a specialist who can guide you. The recognition of the eConsult code has been very helpful with CMS, value-based care, risk sharing, and the increased acceptance of telehealth through COVID are all things that are working in our favor to make this type of a model, which was radical back when Paul and I and others were talking about it, is now much less radical than it used to be. And we are very optimistic that we will continue to see more uptake and adoption of systems like this. And the presence of an HIE that would facilitate the exchange of information across different systems and is something that I'm extremely excited about. And I'll end just with the last slide with one just personal anecdote. I did my internal medicine residency at the Yale New Haven Hospital system, which is a very good system for, among other things, turning out great cardiologists. And I think about half my class went into cardiology. And I told one of my preceptors at the time, one of my attendings, that I was planning on going into general internal medicine and primary care. And he said something along the lines of, "Why would you waste your skills doing that?" And, that stuck with me to this day. It upset me, obviously. It made me feel a little bad. And I've been on a personal mission to prove that he wasn't right. And I think part of really making primary care everything that it can be, an intellectual challenge, a meaningful personal challenge, part of that is being able to have ready access to specialists who can help you and guide you through the rapidly changing healthcare environment and all of the things that we need to know. And I feel a lot more empowered to see patients, manage them, take on new things when I have that digital connection. And so for me, eConsults has become a personal mission to make it more possible for primary care to be, I think, the profession that it should be, that it was intended to be, and that I think it can be. So on that note, I will end and turn it over to our next presenter. Thank you so much.
Thank you, Darren. I think that many of us who are in primary care feel similarly, but I also think that getting into digital medicine offers us a real tremendous opportunity. You should probably be able to see now the poll results from the last poll, which basically said that the most significant difference between the standard referrals and eConsult referrals, the people who answered this, they really felt most the improved communication between providers was one of the most significant differences. And then the other one is really real-time transitions in care. You should now also be able to, I will open up a new poll for you, and you can kind of answer that over the next 5 minutes as we move in to our next presenter. The poll question is, what do you perceive the biggest benefits for patients and providers? And go ahead now, let's go down and let us have Dr. Mark Rabner talk with us a little bit about a transition to a solution that they have been carrying out and is maybe potentially available through some of the same technology that our HIE vendor in Connecticut has. So Mark, take it away.
Thanks, Tom. Appreciate it. So yeah, as Tom mentioned, I'm going to talk to you today from the perspective of a health information exchange. So we're working to really improve care coordination by implementing a closed loop referral process, but that's focused on social needs and connecting patients to social resources. Now, obviously, this is a little different from clinical referrals, but the approach would be pretty similar. Next slide, please. So before I get into the work around eReferrals, I just want to spend a minute describing CRISP, which is the Chesapeake Regional Information System for our patients. And we're the state designated health information exchange for Maryland, but also provide the technical backbone and additional services to support the HIEs in West Virginia, District of Columbia, Alaska, and most importantly for this conversation, Connecticut. And we seek to really advance health and wellness by deploying health technology through cooperation and collaboration, which is very relevant for this conversation. You can see from the stats on the right for a typical week, just to show kind of the scale that we're working at. Next slide, please. So I want to give a brief overview of some of the tools that CRISP has in place that really improve care coordination between members of the clinical care team, which including primary care and specialty care. And this really falls into two categories. The first of which is point of care tools, where as a user, I can log onto the HIE, either using a web portal or an app that lives alongside the electronic health record. I search for my patient, and there I can see clinical notes, I can see encounters, members of the care team, labs, imaging, et cetera. So if I'm a primary care clinician, I can see specialist notes or discharge summaries for patients that I'm seeing. The second category is our Encounter Notification Service, or ENS. And this is really a method to push notifications based on certain populations. There's kind of this standard, which is being identified of patients' admissions or discharges from the hospital, but we can also drill down to specific patient populations, like I want to be notified when my patient has their third ED visit for asthma or is discharged after having a hip replacement. And so that's to say we already have tools in place that improve coordination within the clinical delivery system, but we've had requests to expand that coordination to include data outside of the walls of the clinic or hospital and include the social care sector, like community-based organizations, social service providers, or government agencies. And so on the next slide, I'm just going to get into this approach from the right of your screen. Really bringing in social care data into the health information exchange includes things like screening data, choosing a resource from a resource directory, offering that resource to patient with consent management, referring, which we'll talk about more, and evaluation of those other areas. I'm going to focus obviously on a closed loop eReferral today, but I wanted to lay out some of the challenges and features of our system to help describe the approach that we took. As an HIE, we have a lot of stakeholders and with a lot of different heterogeneous needs. We also know that clinical and social data are typically siloed in their own systems, and our stakeholders have already invested in tools and workflows and systems. And so we needed to build tools that can really meet those challenges. And so in order to do that, we really prioritized interoperability and integrations. We wanted to create a system that was agnostic to workflow and systems and tools that were being used, while also creating this whole person record. Next slide, please. So our goal with closed loop referrals is really to improve coordination between healthcare and social care. And today, healthcare stakeholders can view the social needs interventions and the outcome of those interventions within the HIE. Over the next year, we'll be expanding that access to include relevant patient data from other social care stakeholders and vice versa. So social care stakeholders can see clinical data with patient consent. And because we had such heterogeneous group of stakeholders, we needed to really meet them where they were. And that's by capturing referrals in 3 different ways. And that's what's depicted on the right. First, we have social care provider systems that live in silos. So we can actually integrate directly with community-based organization databases. For example, and this is purely an example, this doesn't exist yet, but we could integrate with, say, the Transportation Authority to identify patients that have needed services for medical transport. They could share that information with CRISP so that the next time that patient's admitted to the hospital, the discharge coordinator can see that that patient has needed transportation services in the past, and they can set up transportation and help expedite discharge. In the second box, we have other clinical partners that are using social determinant of health network providers like Aunt Bertha, Unite Us, and NowPow. And so if I go to a hospital and that hospital uses a network referral system to refer me to utilities assistance, today that data stays really in that system. And other members of the patient's care team really never see the information of the resources that's supporting me. So we're working today with Aunt Bertha to basically be carbon copied on their referrals so that we can share that information with other members of the care team and it's not siloed in that system. And last, which I'll talk a little bit more about in the subsequent slides, is that we have stakeholders that don't have referral systems. And so they asked CRISP to help them build a basic closed loop referral system where the HIE participants can log on to CRISP and make a referral to about a dozen or so different community-based organizations or government agencies. And so in the next slide, I'm just going to dig into what that workflow looks like a little bit with an example from Maryland Women's, Infants, and Children's program, which provides nutrition support for eligible families and has pretty good evidence-based outcomes. So on the left, you have a pregnant woman with food insecurity that could benefit from WIC. The medical professional then refers that patient to WIC by logging on to CRISP and the closed loop referral tool. And then WIC receives that referral and closes the loop back with CRISP. And I just wanted to highlight this closed loop piece because we think it's crucial for this coordination. As typically as it stands now, it's typically a black box. You make a referral to WIC, whether it's through fax or phone, and you don't know what happens with that outcome. And so this helps provide closed loop data back to the organization or person that made the referral and to other members of the care team who can then see that that referral has occurred. And the next few slides we'll go through pretty quick, but it's screenshots of what that looks like. This is basically logging on to CRISP, pulling up the referrals tab. You get some auto-populated patient information. On the next slide, you can pick from a number of different community-based organizations. You hit submit. And then on the next slide, the community-based organization will get a view within CRISP of all the patients that they've received a referral for. They can manage that referral within this tool. And when they update the referral from this referral status, you can see in the third to the right column, that updates downstream systems. So in the next slide, the person that made the referral can see all the referrals that they have sent and the status of those referrals. Next slide, please. And so you can see at the bottom row, this patient has been accepted to the community-based organization and it was accepted on September 24th. And so you can get this closed loop information back. Let's advance to the next slide. And I'm going to skip this one just for time. So the next slide shows basically how this information is displayed within our app that lives in context with the electronic health record. You have a social needs data tab, and when you pull that up, there's a referral history sub-tab, which then will display the referrals and the status of those referrals to other members of the care team. So that even if I didn't make the referral or wasn't involved in that closed loop process myself, I still now can see what resources my patient's receiving. So next slide. Yeah, that's all I have. So just the big takeaway there is that the HIE can be a good partner to help enable eReferrals while also communicating the referral and the outcomes to the rest of the patient's care team, and has really great tools to help improve care coordination. And since we help support Connie, Connecticut's HIE with their infrastructure, this could be used to help support Connie as well.
Excellent. Thank you, Mark. And we'll get into a little bit of how we can think about Connie's involvement as we ask the panelists at the very end to kind of give their thoughts, like how would an HIE best be utilized for carrying out activities that they like or they've noted. To follow up on the poll results that we had before, what do you perceive the biggest benefit of eReferrals? For those who did answer, better access to specialized care was there, and reduced wait time and lower medical care. I'm going to open up the last poll, which we will then also leave open with the challenges that the people might experience. While that's open, I'm going to share a little bit of information. If you go to the next slide, about a survey we've done in Connecticut, some of you may have responded to, about eConsults and eReferrals, specifically thinking about whether there's interest in delivering this through our health information exchange. We went to both primary care, specialty providers, and actually to dentists and pharmacists. And so we got quite a bit of feedback from over 500 full responses. Interestingly, a number of dental providers said that they'd be interested in joining the health information exchange, and that they probably would be able to use it to improve their clinical care. For clinical providers, they said that greater than 60% of them would be somewhat or extremely likely to send an eReferral through Connie, and also an eConsult, similar responses. And they think that it would be extremely or moderately valuable to receive an eReferral or eConsult through our health information exchange. So that's actually really promising to suggest that we've got a real opportunity to utilize our health information exchange. If you go to the next slide, this basically says that if we would develop something that was allowing this to occur within the state, greater than 60% of our participants in the study said that they would be interested in utilizing that service, and that it would probably really help improve our consults. So I think this actually is a challenge to us, and I'm going to open the first question to our panelists. If you go to the next slide, the first question to our panelists is going to be, how could you envision a state health information exchange actually being innovative and creative in the way that it allows for eConsults, eReferrals, all the things that we've been talking about today? What would be on your wish list? Paul, let's start with you.
Yeah, so when we first launched eConsult, we were doing so in a really diverse milieu. Obviously, in our medical system, we had a medical record, but we were serving, like I said, over 200 different FQHC sites, all of which were on any of a dozen or more records. And so we used a neutral third-party web platform for everybody to communicate on. But again, it did not interface with our medical records. And since about 70% of all of our eConsult requests came from our own system, we built an interface between this third-party web platform and our Cerner EMR. That still meant that, about 30% of the eConsults, the record was still just saying on eConsult, it wasn't going back to their individual EMRs. So I think the place where if an HIE was part of the facilitation of the information exchange, that iterative dialogue, the attachments, and that HIE was already communicating with all of those individual EHRs, then that could help route the in-dialogue results back to the EMRs of all the different users in the community. So I think there's a lot of potential, especially for the fact that the HIEs are already building those interfaces with a cohort of EMRs.
And I'm going to just remind folks that they can add their own questions into either the chat or the question and answer box. And then I'm going to pass this same question over to Darren. And I know, Darren, you've done deep thinking in Connecticut about this. So share your thoughts.
Yeah, you asked how the HIE could be creative, I think was the word that you used in addressing it. I actually don't think you have to be very creative. I think we need an HIE that allows providers across different systems and different EHRs and such to be able to share clinical information. It would make our work enormously less difficult than it is, because the first thing we learned when we copied Paul and set up a system similar to LA County was that primary care providers, where it was not mandatory, absolutely would not log on to a portal outside their EHR and type up their question and upload documents. They wanted to stay in their EHR, and they wanted the consult note back to come back in their EHR. And so, rather than fight that, because we didn't have a mandatory system, we built a whole, I would call it a manual workaround, where teams of referral coordinators would take on that role. The provider would submit the consult in their EHR, but the referral coordinator would collect the information, and as I mentioned, fax or secure email or SFTP or now more commonly now direct message that into the system that our specialists would using, and that is working, and it served us well, but it's an enormous amount of additional work. I think that having an HIE infrastructure would allow, whether you're on Allscripts at ProHealth or whether you're on ECW at CHC or whatever system you're using, would make that whole process of letting the information flow back and forth to meet the primary care provider's principal requirement, being that I don't have to leave my EHR environment when I'm seeing patients. So I'm really excited about the work that you all are doing to move us towards a day when that might be possible.
Excellent. And Mark, you've been working in this HIE space a bit and have given a lot of thought to eReferrals and eConsults. And so you have some of the technology knowledge and some of the challenges. So share with us your thoughts on that.
Yeah, I mean, I couldn't agree more with the prior two comments. I mean, interoperability and integrations are the key to scale. Staying within workflows are crucial to decreasing burden and allowing clinicians to save time and not have to remember 6 different passwords. I think related to social needs specifically, and probably related to, based on what Darren said, related to clinical referrals and consults, is the payment and reimbursement incentive structure for the states. For social needs, getting paid for fulfilling a referral is often not an additive reimbursement. It's basically they get a grant and they have this X amount of money to spend, and they are not getting increased incentive for fulfilling that referral. And so those kind of structural payment reform really needs to be in place in order to see scale across the board.
And I actually think it might be helpful, Mark, if you were able to describe for the panelists and the participants a little bit of how the in-context app works within certain EHRs that you're capable of doing it a little bit more robustly. That may actually help them, in thinking through how the actual clinicians might experience this. And maybe if we go back to the slide where the in-context app is on, I think, 3 or 4 slides back, you might be able to describe for folks a little bit about how that functions.
Yeah, sure. So if you go forward about 3 or 4 slides, there's if you keep going forward, I think.
Next one.
Yep, that one. So the in-context app basically lives side by side with a few EHRs, including Epic and Cerner, where basically you pull up your patient chart and that patient information is automatically pushed to the in-context app, so that automatically the patient record within the HIE is pulled up alongside that records. You don't have to flip back and forth between platforms. And you can see from the first panel here that we have medication management, which is the PDMP, clinical data, which is what I was showing before, with documents, labs, images, care coordination, which helps explain who's a part of the member's care team, then social needs and data we actually get from claims as well. So we can present this data in within the clinician's workflow and build tools in here that can help really improve that coordination.
Excellent. So we're at time, and I really want to thank our panelists and share back with you a little bit of the last poll results. We're integrating with different EHRs and reimbursement were the things that folks who answered suggested might be challenging. Thank you so much for our panelists sharing their time and their experience. This information on this webinar will actually be available online within a week or two. For those of you who are seeking continuing medical education or pharmacy education credits, you will receive an email, and then we'll have to complete an evaluation, and we will follow up with that after this session. And I really want to extend our thanks again, and look forward to talking with individuals in our next presentation, which I believe will be about imaging and image sharing within a health information exchange. So we'll be looking forward to creating the time and the space for that, and we'll get out to folks with that when that's going to occur. So thank you all.